you can mute and unmute and ask them during the Q&A session or after the presentation. And I think that's all I have. So Dr. Advani, I'll let you take over.
Sure. Thank you everyone for having me today. I am Dr. Rashmi Advani and I'm currently a second-year GI fellow, and I'll go over what that really means. But it's truly a pleasure here today for, speaking to you all about what I do and why I love what I do. And a lot of what my work on social media has been trying to communicate and connect with people in the pre-med, med, and resident paths of life, and try to educate them on gastroenterology. It's a resource that you guys are incredibly lucky to have, just because it was something that I didn't really have myself when I was in your shoes. So hats off to Natalie and McKenna for really bringing this together. So I'm going to start sharing my screen, and then let's see. Is there a way? Okay, I think I don't really need to. Okay. Maybe I could do it this way. Okay, so you guys are seeing my screen. I'm just gonna start here. Okay, do you guys see my presentation? Okay, all right. All right, so I'm just gonna start. So as I mentioned, I'm a medical doctor. I have an MD degree, and I also recently became a diplomat of obesity medicine. So it's a second board certification. So I'm going to talk a little bit about what life is like in gastroenterology, and a really exciting case that I feel like everyone can really relate to, even if you're not a gastroenterologist or even a resident or even a med student for that matter. So something really relatable. My Instagram and Twitter handles are here. So if you have any further questions, you want to DM me, you want to look through my content, I speak a lot about the field, being a woman in GI, women in medicine. So if that's something that interests you, definitely check it out. Okay, so, all right, so how did I get here? I wanted to create this schematic because I think conceptually it's a little bit difficult to learn all the steps that it takes to really get to where I currently am. But a bunch of you are in your undergraduate years, so that's generally 4 years. And then you apply to medical school with your amazing application, and that's another 4 years. And then you do what we call an internal medicine residency. And there are many different kinds. I just like dropped my charger, but there were many different kinds of residencies to choose from. And each residency you can specialize. And there are only like certain ways to specialize when you choose the residency of your choice. So I initially thought I was going to become a surgeon. I think a lot of people going into medical school think that they are going to become surgeons. And I think to a good degree, I was able to marry my interests in procedures and surgery with gastroenterology, which ends up being a very procedural field. So the reason why I included the additional year, 3 years of internal medicine residency plus maybe a year, some people choose to do what we call a chief year in internal medicine, and that's an additional year. Or some people decide that they want to do like a research year or whatever, master's. So there are a lot of opportunities to have additional experience before you apply and become a gastroenterology fellow. Gastroenterology fellowship in general tends to be one of the more competitive specialties to apply to, just by the nature of the field. It's very attractive to a lot of people because of some of the reasons why I mentioned earlier. There are procedures, there is flexibility in your schedule. It's a great compensation. It's a great work-life balance. It's really exciting. The pathophysiology is really exciting as well, and it's a very innovative field. A lot of people are really making big moves in this field. Even as I've gone through my training, the field has like changed remarkably. And then then there's a fourth. So then gastroenterology fellowship is 3 years, and then you can choose to do essentially a 4th year in GI fellowship, which is an additional year, or 2 years depending on what you choose. But it's a sub specialty. So really the only way to become a gastroenterology fellow is having gone through all the first 3 initial steps. Okay, so what procedures do we do in gastroenterology? So we do a lot of procedures, and I think this really becomes a lot of the attractive qualities of GI. We do have a lot of clinic-based practice, long-term care, which is attractive, but the nice mix with procedures ends up being its biggest selling point. So we do upper endoscopies, and I'll show you a picture of what that looks like. Colonoscopies, this procedure called ERCP, where we can perform procedures in the biliary tree or to treat pancreatic disorders or liver diseases. Endoscopic ultrasound, so it's basically what it sounds like. It's an ultrasound in the GI tract. It really helps hone in on some of the structures that we can't see on CAT scan or MRI, and really can give us diagnosis for cancers or lesions in the GI tract. Enteroscopy, which really just means you're going into the small bowel. So upper endoscopy, you reach only the first part of the small bowel, and colonoscopy, you really reach the cecum. So there's this whole segment of bowel, the small bowel, that can be evaluated, and that's through enteroscopy. Capsule endoscopy really is a minimally invasive procedure where someone can swallow a tiny little pill that has a camera at the end. It's a really cool system, and it takes pictures along the GI tract, and really helps to reduce any unnecessary procedures, and gives you an idea of what kinds of interventions you want to perform if you see something abnormal, depending on what it is. Sigmoidoscopy just means that you're going to a limited distance into the colon, called a sigmoid. It's usually towards the end. I don't know why manometry came out with such a large font, but there's motility tests. So really, it's to look at the pressures in the GI tract, see what the motility is like, if it's moving well. A lot of people with GI issues, some of their diagnosis of their GI conditions can be made through manometry. pH impedance really just looks at the level of acid exposure. So if people suffer from reflux, we utilize this modality. Anoscopy is what it sounds like, just a scope into the anus, and really some of us can also treat hemorrhoids and band them. More recently, and this is what I was talking about in terms of how innovative the field is becoming, but we can do bariatric weight loss procedures endoscopically without having to even cut open the skin. We could do it all endoscopically, and that's pretty minimally invasive. Anti-reflux procedures, and what we call third space endoscopy or endosurgery. So really there's a big move, I think, in general in medicine to perform minimally invasive procedures, and GI really is at the forefront of it. So what diseases do we manage and what we treat? It's really, so the nice thing about GI pathophysiology is that it's heavily connected with every system in the body. Infectious disease, cardiovascular, the nervous system. There's a lot of interplay. It's a large segment of the body that you're covering, right, from the mouth to the anus, and then there's some structures, intervening as well. So we treat and manage, excuse me, inflammatory bowel disease, constipation, diarrhea, irritable bowel syndrome, cancers of the GI tract, luminal disease and strictures are really any narrowing of the GI tract. People can't eat. If they have any blockages, we can go in and try to dilate them and open them up. Celiac disease, so that's gluten sensitivity, pancreatitis, so inflammation of the pancreas. It's one of the organs in the GI system that we treat. Gastroesophageal, basically GERD, that just means GERD. Barrett's esophagus, which is a pre-malignant condition related to reflux. Colon cancer screening and prevention. So if you guys ever head down to my Instagram, I talk a lot about colon cancer screening and prevention and colonoscopy and preps and stuff like that. Really exciting stuff to have a discussion about. And motility disorders like achalasia, some of these diagnoses and diseases are a little bit more specific to your education when you're in medical school. So don't worry if you don't know any of these terms, but hepatobiliary diseases, which means that any disease that involve the liver and the biliary tree, the gallbladder, liver disease and cirrhosis. Cirrhosis just means scarring down on the liver, and we manage the complications of that or try to prevent scarring down the liver. And then anorectal function and motility, really, people who suffer from really terrible constipation or diarrhea, or they're not able to control their bowels. We try to figure out whether they have any like nervous system issues that are causing that, or is it psychosomatic? There's a bunch of reasons. But so where can you find us? We work really in every single type of setting in medicine. We can work in academic institutions, which are large tertiary, quaternary care centers. You can really try to divide your time into clinical and research time. Sorry about that. And we could be in community-based practices or hospital affiliated. So you're not 100% at your time at an academic institution, but you're affiliated with a hospital and able to have those resources at your disposal. Excuse me. And then private practice, there is private practice in GI. It's very much flourishing, and a lot of people really rely on that level of care. Locums, so locums really just means that you can work in different hospitals, different locations, different settings. Excuse me, guys. I don't know why my throat is clogging up right now, but so a lot of people also ask me like what the hours are like and what the compensation like, and I think that it varies. It varies on your expertise, what the availability is, what the location is. It also, compensation also varies based on that as well. In academic institutions, it could be on the lower side, but then if you have more positions that are administrative or director, or if you're like kind of high up in the ladder, that goes up. Excuse me. And the hours vary. So you see people who work 40 hours a week, but some people who work 60 hours a week. And it really depends on like what your schedule, how you design your schedule. And that's something that you could totally do in gastroenterology. Okay, so life as a trainee and fellow. So I'm going to share some pictures of me and my colleagues. And we're a really fun group of people. And actually one of the major reasons why I decided to choose GIs was because of the people in the field. And really, I mean, how seriously can you really take yourself if you're talking about poop all day? Which is not really what we do, but it's something that I think adds to how great the field is. Just the people are amazing and very brilliant and smart. So this is me and my co-fellow and my attending. We did a run and a walk. This is again my other co-fellow and one of our attendings. We're really close-knit group. This is the beginning of my fellowship, almost, I would say 23 months ago, pre-COVID. All of us our rounding and the inpatient service. Our attending is the doctor in the glasses on the bottom. And then there are some med students here. There's a 4th year, there's a 3rd year med student. There's my senior co-fellow in the center, and then my co-fellow, same class, the one who doesn't have hair on his head. And then this is, you know, me and my co-fellow and my co-fellows and my my attendings, all of us women in GI. So this is a really nice picture that we took a couple months ago when it was nice and bright outside. This was the beginning last year, about a year ago, I would say, when the first year started, and all of us thought we would just take a funny picture. So that's what we did. I think a lot of failed jumps there, but really it's a fun group of people. People in GI are, you know, we love to laugh at ourselves, and we love to work as part of a team, and we're very close together. This was when one of our attendings got another job. So we all got together, got her a gift. This is in the endoscopy suite. You can see kind of what the back of that room looks like. But and on the left, I don't know if you can see in the bottom, that's kind of where our scopes are. But it's a great group of people in a really exciting field. And we need more women in the field, of course, as you can tell just by looking at that picture. Definitely could. And then we go out, we have fun. People bring their spouses and their friends. And one of the person on the right is also one of our attendings. So it's a really close-knit community. And there's, you know, once you reach at the level of a fellow, you're more or less, you know, one of the gastroenterologists. Like you're not like just a trainee, or you're not like below anybody. And I think that's something that's really nice about GI. This was Halloween, pre-COVID. This was a good day, but these are just my co-fellows and I. All right, let's talk a little bit about GI. So, so this is the anatomy. I liked both pictures. I want to show you guys both pictures. The left one just because just so you had an idea of where these things kind of sat in the body. You know, pre-med school, a lot of this stuff, you know, I didn't really know or was able to conceptualize until I took anatomy. But the left picture just really shows you, you know, how expansive the GI system is, and it goes from the mouth and then all the way to the rectum and the anus at the bottom. And then this right picture, I actually have this up in our offices. I think it's a really beautiful picture of the GI system just because it looks, you can see the vasculature, you can see all these different organs. So all of these organs we manage and we treat, and we really do our best to manage these conditions that involve any of these organs. And you can really tell like it's pretty interconnected just by looking at the picture. There's, you know, a heavy interconnection with the vascular system, the nervous system, which you can't really see here, but the pancreas, the liver, the gallbladder, these are structures that are not typically kind of in the lumen of the GI tract, but, you know, structures that we primarily deal with as well. All right, so I'm going to show you a little bit more about the stomach because our case deals with the stomach. So for those of you who haven't taken an anatomy or have but forgot this, which is totally understandable, the stomach is divided into several parts. The cardia, which is up here at the right. I'm just going to see if you guys can see my pointer, but the cardia here. Actually, I'm trying to see. Can you guys see my pointer? Is that like a, hold on.
Yes.
You can, right? Okay, good. So up here is the cardia, and then the fundus is really up here. It's the dependent portion of the stomach. This is really just like a 2D image of what the stomach looks like, but endoscopically, and like really, if you ever open up an abdomen or a cadaver, the stomach doesn't look like this. You know, there's parts of the stomach that are more posterior, more dependent in the back, and some that are more in the front. So it's really important to know your anatomy and have, you know, at least cadaver labs to understand this part. But so then there's the fundus, and then you have the body, which is, you know, the large portion over here on the right. And it's the greater curve, the lesser curve of the body. And then you have something called the antrum, which is right before the sphincter. So there's two sphincters here. One of them is not that clearly depicted, but it's the lower esophageal sphincter, which usually sits here. It allows passage of food through, and then it prevents reflux. So it really has its unique function. And even so, the pylorus here, the pyloric sphincter is a sphincter that also, you know, opens and closes depending on food content that enters the stomach, and allows passage of food. So you could just imagine, like, there are several areas of the stomach that could be affected by various diseases, and we really treat all of it, or most of it. And the duodenum is the first part of the small bowel. So usually in our upper endoscopies, we can get to the duodenum, maybe a little past if we try to stretch it, but that's generally where what an upper endoscopy entails. You look at the esophagus and you look at the stomach. The stomach is, it consists of several layers. So you have the serosa, you have the muscularis externa, which has 3 different muscle layers. It's a pretty thick layer compared to other parts of the GI tract. The esophagus is a pretty thin-walled structure. The right colon is pretty thin compared to left colon. So all of these factors we take into consideration when we're thinking about certain diseases that might penetrate through, like cancers. You know, having an understanding of actually even the layers of the luminal GI tract is important. All right, so this is just kind of what we see endoscopically. Sorry, it's a little blurry, but I hope this kind of gives somewhat of a picture of what we do. So as I mentioned, things that look, you know, the way they do on a 2D image, they don't look that way endoscopically or cadaverically. You know, the veins aren't blue and the arteries aren't pink. You know, that's just for illustrative purposes. But when you're inside the stomach, what you're seeing, all that pink, is just like normal mucosa. And then these circular folds, actually I'll go up on the top, but like really that black, so on figure B, if you can see my cursor, there's this black thing here is actually our scope, and it's our scope looking back on itself. So this is, if you were to imagine, the esophagus is just beyond this. So we go down the esophagus, we look straight down, and then we curve back up. And this is what we're looking at. So the fundus is here, the cardia is here. And really that's how we enter the stomach. We enter it through this direction. So the black is just the scope. The pylorus, I just wanted to show you how this looked like. Pylorus actually looks like a sphincter. It's like this tiny little hole that, you know, sometimes like can give you a little resistance if you're trying to get through it, but it serves a lot of function, and it allows the entrance of food content into the small intestine. So if you look at these circular folds, so that's where you can see this image in the small intestine, which particularly in the duodenum, which is the first part of the small bowel that you enter after the pylorus. Really, if, you know, once you get really good at stuff like this, if you showed a picture of any part of the GI tract and showed a gastroenterologist, they'd be able to tell you where it is just by what the mucosa looks like, you know, what the folds look like. So all of these parts of the GI tract, they have their very defining characteristics. Oh, I hate that this is so blurry. Okay, so I just wanted to show here that there was, you know, each part of the stomach has its own has its own function, and that function allows us to do the things that we normally do when we digest food. So the stomach is protected by a mucus layer that's enforced by bicarbonate. So usually the lower esophageal sphincter in the blue circle and the cardia, which is up here, that is, it allows secretion of mucus and bicarb in the layers of the stomach, and the sphincter, like I mentioned before, the function of it is to prevent reflux, but also allow for entry of food, and it regulates your burping or your belching. So if you try to make yourself burp, you're really utilizing this mechanism here in the stomach. And then the fundus and body, which is here in the yellow, so it has its own purpose. Really, the main purpose in this area is acid secretion. So acid needs to be released in the stomach to help start digesting the food that you take. And there's also different enzymes that exist in this area, like pepsinogens and lipase, so that breaks down fat. And as I mentioned, the fundus is the dependent area of the stomach. So like if you're taking in food and you start feeling a little full, it's because your fundus is getting full, not the entire stomach. Maybe the entire stomach, but depending on how much you're eating. But really, like that's just kind of like the reservoir of where food usually sits. And then the antrum and pylorus has similar function to the lower esophageal sphincter and the cardia. Again, it's like a sphincter region, so it allows passage of food. It has a lot of contractions. So like if you even see this endoscopically, you can see like these contractions happening and the stomach is just kind of like moving. It's really, really cool. I wish I could show you a video of that, but it allows for like mixing of food, grinding of food, and it regulates emptying. So if you're feeling full, it's usually also that like your sphincter, your pyloric sphincter hasn't opened and let that food pass. Okay, this is just another picture just showing what the layer of the stomach looks like in a biochemical fashion. And this is important just because we are going to talk about a case that involves somewhat of this mechanism, but you have surface mucus cells, and really bicarb is pumped out through these cells into the mucus bicarbonate barrier, which is a protective layer of the stomach. And when you disrupt this barrier, that's when bad things happen or not so pleasant things happen, and people get ulcers or people get infections and people get inflammation. So this is just something to really just keep in mind. And then this layer separates really all that acid exposure that is needed to digest the food and the epithelial cell. So if you notice that this barrier gets affected or gets disrupted in any way, and the acid has its face time with the epithelial tight junctions in the cells, that's when you start seeing damage, because that's not supposed to happen. There is supposed to be that mucus barrier. So anything that affects that bicarb layer, that depletes the layer, affects it in any way, can really wreak havoc on your stomach. All right, so let's talk about a case. How are we on time? Okay, so I'm gonna just go through this fairly quickly, and there are gonna be some questions. I don't know how we wanna do this, but maybe if you guys wanna unmute yourselves and answer them as we go along, I think this will be more helpful and more interactive. You don't have to put your cameras on, but maybe feel free. No answer is stupid. So the case is a 35-year-old woman with a history of knee pain. She presents with black stool for one day. So this is a pretty common scenario that we see in the clinic, we see in the hospital, mainly hospital. But she's had about 4 episodes of this black stool since the morning, is now feeling fatigued and dizzy. On additional history, she was also having abdominal pain for about 2 months leading up to when she presented. So further history, no vomiting, no red stool, no fevers, chills, headaches, no trouble swallowing or weight loss. Really, these are the questions that we ask when we get consulted in the GI service. Her medication, so getting a full medical history is really important. And you guys will see this, in medical school and through your training or whatever medical profession you decide to go into. getting a medical history, getting a thorough history is really important. So her medication, she takes ibuprofen, so that I feel like all of us take, but 400 milligrams 3 times a day for the last 2 months. And she's been on vitamin D. And her surgical history, none. She's had no surgeries. Her mother had gastric cancer and her father had colon cancer. And she doesn't drink, she doesn't smoke, she doesn't use any drugs. And her medical history, she has patellofemoral syndrome, which is kind of like just inflammation of the kneecap. So her vitals and her physical exam, maybe I can ask the group, what vitals would you be interested in this case? You can even write it anonymously in the chat.
I mean, you'd definitely be taking like blood sugar and glucose levels.
Okay, yeah, definitely. What else do you want?
Weight, and I guess like comparing it to if she has previous records, comparing her weight to see if there's any gain or loss that's like significant.
Great, great. These are good. That's very good. So definitely checking someone's weight, seeing if they've lost any significant weight, especially with her family history of cancer. Yeah, of course. Anything else? What are kind of like the general vital signs that we look at?
Somebody had put in the chat previously that you'd want to look at if she's had a recent case of nausea or vomiting.
That's good. So that's part of your history. That's good. That's very good. So she doesn't have any nausea, no vomiting. So some of the vitals to look at would be her heart rate and her blood pressure. When you start evaluating patients, the first things you want to look at is how sick they are or how sick they can be. And vitals and their physical exam is a big part of that. So if their heart rate is through the roof or their blood pressure is tanking, you know that they're not doing too well. So that's something you want to definitely understand and try to evaluate first. So her heart rate is 110. So the normal heart rate is anywhere from 60 to 100, and her blood pressure is fine. It's 110/70. It's still in the normal range. It's maybe softer. We don't know what her prior blood pressure was. She doesn't have a fever and she's saturating 100%. And I could just tell you right at the bat, her weight was stable, but excellent response. Her physical exam, really, you do really the whole physical exam. You do the head and neck exam, cardiovascular exam, respiratory exam. For GI, really, from our standpoint, we focus on the abdominal exam and the rectal exam, especially if someone is having black stool. We want to see if is it truly black, because if it's black, then that might indicate something in terms of what's going on. So you do a rectal exam and you see black stool, and it's black, like it's like, this color. It's not like kind of, off, green or something. So it should be black. So what's the next step in the evaluation? So this is another question for you guys. Any thoughts?
I mean, would you send like stool samples to get checked, like lab work?
You can definitely. So you're right. So lab work, right? So what do you want to learn? What do you want to know about in the labs? Like, what's your concern with someone coming in with black stool?
Maybe like blood loss.
Yes, exactly. Blood loss. And you're thinking that maybe she's having a bleed, possibly, who knows? But if someone's bleeding or you think they're bleeding, you want to know what their hemoglobin is. So, and then what that means according to their baseline. So you brought up a really good point earlier, like looking at what the previous numbers have been like, right, in terms of the weight. So the same applies to looking at labs. So the labs, her hemoglobin's 8. Now, is that normal? Do you guys know if that's normal or not?
I don't think so.
Yeah, it's not normal. I feel like I'm giving you guys leading questions, but it's not normal. the normal hemoglobin for a female, at least, is above 12. So she's about 4 units down from normal levels. And assuming she's like a normal, like no other medical issues, no anemia history, I'm assuming her hemoglobin at baseline is probably 12. Although with her particular case, we didn't have any prior records, which kind of sucked. But her hemoglobin was 8. So, and then her creatinine is 1.4. So really, this is just a marker of what the kidneys are doing. If someone's dehydrated, some people who, if they lose blood, sometimes they can lose enough volume that it can affect their kidneys. And then her rest of her labs were pretty normal. Her sodium, her platelets, her INR, which is a coagulation number, her potassium, her liver panel, her white count, everything was normal. All right. Anything else that you would kind of want to know or about her case after that?
Can you talk about what you did treatment-wise for it?
Definitely. We're definitely going to get there.
Okay.
This is just the evaluation. This is just kind of like in the beginning before you decide what you're going to do.
Well, I think it was just, oh, sorry.
No, go for it.
I think it was just interesting to see. I mean, I'm not really like informed, but too much on this like specific, the specific conditions that she has, but would her condition, the like kneecap inflammation, all of that, would that have anything to do with what's going on in her GI system?
Possibly. So the fact that she's having inflammation in her kneecap, she's taking this medication to help treat that. And this medication is possibly the reason why she is suffering from this issue. But it's all very related, and that's a really good question. So you definitely want to figure out if people have other conditions making them take certain medications that might not be so good for them. Okay. So would you get any imaging? What's on your differential? So some questions to really ask yourself. Was there any data to support or refute components of your differential? Are there any positives or negatives? So really all of everything that you guys are learning in undergrad or school, it's to allow you to critically think about things. And medicine is all about critically thinking, right? You use all the information that's in front of you and you synthesize it and you try to come up with an answer, or you try to come up with like an endpoint of some sort, even if it's not perfect. But if you're utilizing those critical thinking skills, like I think, even in hindsight, that was very helpful. But so the next step in management is an upper endoscopy. So basically that first procedure that I showed you, that what we do an upper endoscopy. But wait, would you like to start them on any medications or do anything before taking them for the procedure? So this requires now what you think is happening. So so you mentioned GI bleed or like blood loss. So yes, that's correct. So what is this person bleeding from and where is she bleeding from it? So the first question is what? Like what do you think someone can be bleeding from? Someone so young with no other issues, but is taking a medication that might cause an issue or cause a condition. What condition is that?
I wouldn't know the specific condition, but I would say like maybe because she is taking a lot of ibuprofen, that can like mess up the pH balance and cause like ulcers or things like that.
You said it.
Yeah.
You said it. You know it. It's ulcers. So she has an ulcer, and an ulcers, really, what is an ulcer? It really just means that there is something eating away at that mucosa. Remember we talked about how once you disrupt that barrier, the acid has its way with the cells underneath and it eats away and it causes inflammation, causes a lot of damage. So when that happens, you create ulcers. And I'll show you what that looks like. But ulcers, if you invade deep enough, you can erode into a vessel, and that vessel can bleed. So that's probably what's happening. And the fact that she's having black stool means that it's happening in the upper GI tract and not the lower GI tract, right? Because why didn't I say, oh, she needs a colonoscopy, right? It would be because of the color of her stool, which is why it's so important in our field to look at what the color of the stool looks like. So it's black. And the reason why it's black is because when blood is lost in the upper GI tract, it has time to digest when it starts going down all the way down the GI tract. So we know that if there is enough distance that the blood needs to travel, it's happening more at the top. So the blacker it is, the more at the top it would be. And that's why going from an upper approach would be better, because if it was more red, or if it looked red or maroon, you would think maybe from the colon, actually, from the lower part. So you would decide to go there instead, right? So all of these components really make or break what you do. And procedures aren't low risk procedures, right? We're doing procedures, and it's an invasive thing, and it carries its risk. So you want to go in the right direction from the get-go. So the management of ulcers, you give them blood, right? Because she's losing blood, and you think she's still losing blood, so you give her blood. Make sure she has IV access, so you can give her the blood and give her fluids. Coagulopathy, people have, certain issues with their coagulation factor. Sometimes we give that. Pantoprazole is an antacid. It's a very potent antacid. We give it to the IV, especially if we think people are actively bleeding from the upper GI tract only. And then the question that all of us want to know is, when did they eat last, right? Because if someone ate like 20 minutes ago, then I know that their stomach is probably full of food and they can aspirate when I do my procedure. And aspiration means that food goes into your food pipe and you can aspirate and die. So that's not a good thing. So we have to intubate people, put them on a breathing tube if they ate closely to the procedure. So this is endoscopy. This is what it looks like, and this is how we do it. So really, we take a scope with a long, flexible tube, a light camera at the end, and through the end of the scope, we can snake in instruments and different cool tools to treat whatever we need to treat. So like bleeds, strictures, there's a lot of tools in this area. But this is basically what it looks like. So these are the images I wanted to show you. So if you look at the top two on the left, these are ulcers. These are what ulcers look like. On the right, this is what an ooze, kind of like a oozing or red spot looks like for an ulcer. This is one of our instruments that's coming out at the end of the endoscope. And this is how we deliver treatment. So here, usually we put an epinephrine, which is a vasoconstrictor. It can constrict vessels that are feeding the vessel. So this right here is not normal, right? I showed you pictures of what like a normal stomach looks like, and all this red is not normal. And that means, and if you see this little like line, that's literally a bleeding vessel. Like this vessel is bleeding into the stomach, and it's causing all this blood loss. And this happens, probably an ulcer, happens to be probably an ulcer. So really what we're doing here is trying to save someone's life from a massive GI bleed. And it's really cool when we do things like this. That's why GI is amazing. And so peptic ulcer disease, just kind of going on through the causes. I can always go back to that image if you guys have any questions about it. But NSAID use, so ibuprofen, Aleve, Motrin, any of these medications can cause a disruption in the barrier and cause ulcers and bleeding. H. pylori infection is the bacteria, can also disrupt that mucus barrier and cause inflammation and ulcers, which can also bleed. And then other common causes of ulcers are like stress ulcers, people who are in the hospital for a very long time, big procedures, alcohol use, family history, malignancy, and Zollinger-Ellison syndrome, which is pretty rare. So location, ulcers can happen in the stomach and in the duodenum, which is that first portion of the small bowel I told you guys about. But ways to kind of tell if someone has an ulcer, if someone has abdominal pain when they have a meal, it's not very common, and some people have vomiting. And then duodenal is more common. It's usually associated with H. pylori. It's usually pain relieved with a meal, and people can have dark turry stools. These are the locations of what ulcer, I'm sorry, again, this is like pretty blurry, but this is where ulcers can kind of reside or look like. And then this is just another picture of what H. pylori can do. It can disrupt that mucus layer that we were talking about, and can really allow acid to affect the epithelial cells and erode into those tissues. All right, so my final remark is there are 4 keys to being a great doctor. Find ways to keep learning, avoid premature closure, be compassionate, and be curious. And I really thank you guys all for your time. Do you have any questions? Any comments?
I have a quick question. So I know you mentioned that there's a lot of connections, obviously, between the GI and other systems in the body. And so how do you kind of differentiate whether it's a GI issue or if it's something else, or do you even, communicate and work with other doctors of other systems as well to help a patient?
Definitely. So you gave an excellent question. The thing with GI conditions, if we think it's a primary GI condition, it really depends on what the diagnosis is. So like, say if it's like, if we know that it's probably autoimmune, then we know it's just not not only the GI tract, but it's like all these other systems. But there are autoimmune conditions like scleroderma that sometimes only affect the GI tract. So we do work with other services in trying to co-manage patients, because even people who have, say, like diabetes, for example, diabetes can affect the nervous system. Like, how people get like numbness and tingling in their fingers and their toes. That kind of somewhat happens in the GI tract, where the nerves are affected that innervate the stomach or the GI tract. And if the nerves aren't working, then the GI tract isn't moving well, and people get what we call gastroparesis. And you've probably heard that term before, but it can happen in diabetics. So it's not a primary GI issue technically, but it's caused by like something else, like, an endocrine issue. So there's a lot of interplay. It's not really like there are only GI conditions that happened only in the GI tract, and like if you diagnose them, then that's it. But even inflammatory bowel disease, like Crohn's disease, it can affect anywhere else. It can affect the skin, it can affect the mouth, it can affect the joints. So like that's how it interplays with other services. I hope that answers your question.
Yes. Thank you so much.
Yeah, of course. Were there any questions in the chat box?
Not yet. Feel free to ask them in there, guys, if you don't want to unmute. Do you have a favorite part of your job?
I feel like I'm incredibly lucky to be doing what I do, just because for me it doesn't really feel like work. It feels like I'm having fun at what I would do every day. So I think the things that make my day really worth it are the people that I work with. I think gastroenterologists are great, and there's so many people to learn from. And I like how complex and how much variety there is in the field. Like, there is a lot of interplay with other services and other systems in the body. And I'm a very cognitive, critically thinker. So that's something that gets me up from bed every day for sure.
Right. That's so cool. There haven't been any questions in the chat, so while we wait, if there are any, I'm gonna go ahead and put the link for the Google form so you guys can fill that out while we're waiting for any last minute questions. It should take you 3 minutes. So you just have to put your name and kind of how you heard about us.